everyone. I seem to always get the short straw and get people either first thing in the morning or straight after lunch, so I'll try and not put you to sleep. This presentation is slightly more clinical, slightly less dry than the last one. So let's get stuck straight into it. So when I was asked to consider life-saving procedures performed in the emergency department, I thought, well, let's break it down. Let's look at the airway procedures, the breathing procedures, procedures involving the circulatory system, and those related to disability. That conveniently falls into 4 categories. I've got 2 talks, so we'll attack 2 categories on each talk. I then thought to myself, well, what are the sort of heroic and life-saving procedures we can do with airways? Well, we can really do cricothyroidotomies or tracheostomies. And those of you who were at the airway talk yesterday will have had a go at a cricothyroidotomy. It was quite a bloody experience for all involved, and not least the pigs. And then in the breathing realm, I thought we'd look at thoracostomy. So the red ones, the ones we'll look at, the others we can discuss and mention. All right, so onwards. So we'll look at the airway case. We had a 30-year-old gentleman some years ago, 2008, I believe, who was sitting outside his market stall in the southern Afghan city of Kandahar. Unfortunately for him, a massive IED detonated in a nearby vehicle, decimating the surrounding streets. I think 80-odd people died and removed a lot of the buildings. The patient sustained significant facial injuries and bleeding into his airway. He had altered anatomy and he had a decreased level of consciousness and, as with most Pashtun gentlemen, a massive beard. I was asked to pop along and see if I could offer assistance. So on my arrival, which was approximately 20 minutes after the blast, there was still some significant security issues, and there was sniper fire around and people setting off bombs. And this gentleman's airway was compromised. His breathing was rapid and shallow and noisy, and he was tachycardic and hypotensive. He was one of 3 patients who we went to go and see. Sadly, one of them passed away at scene. We got 2 of them back. That was the scene. This was from a newspaper article about it about a week afterwards. So I didn't actually take this picture. I did have my camera with me, and we will see some shots in a moment. So it was a massive blast, and it did cause significant damage. That was the storefront where he was sitting outside the front of. Apparently, the reason for this had been a NATO convoy going past. Somebody mistimed the bomb, and they were well clear, and it just took out a load of locals. Unfortunate. But there we are. So this gentleman required a cricothyroidotomy in the field. As you can see from the picture, his face is a bit of a mess. He has a large beard there. I've anonymised the gentleman, bagging him because he didn't want to be known. He's a Canadian gentleman. And we had to do a surgical approach to the field. We got his airway secured. We transferred him rapidly. There were snipers active at the scene, so he had to move on. And he was sedated for his transfer as he was demonstrating some movement and looked like he could be in a significant amount of distress. That was his face. We were going to show this just before lunch, so now you can see why I'm frustrated about the after lunch thing. We had to remove his beard, which actually proved that his airway was not significantly anatomically damaged, but there was a vast amount of debris in it from the damage to his face. He was taken to theatre. Facial reconstruction was undertaken and stabilisation. He was actually remarkable. I haven't got the post-operative photos with me, but there was quite a good outcome. He lost vision in one eye, but apart from that, he was mentally relatively sharp afterwards. That's his nose, the white bit. So he lost the vision in one eye. He returned to a pre-mortem level of intellectual function. He was a relatively pleasant gentleman. I met him about 6 weeks afterwards when he was discharged, and I was just wandering through a nearby village, and one of the locals approached me and sort of brought him up and introduced me. He was a very nice fellow. He was very thankful. His family were fortunately very well connected and relatively wealthy landowners, so they transferred him to India for a definitive cosmetic reconstruction. I haven't seen him since. So this is where we come along to the life-saving procedure of cricothyroidotomy. It's the preferred technique in the emergency setting. According to Francois, there is a similar level of complications to a tracheostomy, but it's known to be much easier to do and is easier to teach. It was initially described in 1909 by a gentleman with a fabulous name of Chevalier Jackson, performed by patients who had upper airway obstruction secondary to diphtheria. But there were very high rates of subglottic stenosis. Now, that probably represents the choice of the very rigid tubing that was used at the time and the surgical technique involved. It was then revisited in the 1970s by Drs. Brantigan and Groh, and their series demonstrated only 6.1% of patients had significant complication. At that point, it was embraced by a wider crowd. It's still rarely used in the emergency department. In hospital intubations, according to Blair et al., only 1% proceeded to getting a cricothyroidotomy, but up to 10.9% of pre-hospital intubations required a cricothyroidotomy. Now, whether that represents a different patient cohort we've seen in the pre-hospital environment, or whether that represents a different approach to the airway, I'm unsure, and the authors weren't clear. Practice makes perfect, and as it's a rarely used technique, we shouldn't really be trying it out for the first time in anger. So it's best to attend practical sessions such as the airway workshop, where people discovered the pros and cons of different approaches, where you can practice under supervision, where you can cut your teeth before you try this out in the real world. I've been mainly spent my career looking for situations where this sort of thing does happen, and I've only managed to get 4 so far. So even if you go out looking for trouble, they're still not a common procedure. So the indications for this, it's the failed airway. You can't intubate, can't ventilate, nightmare scenario. There are many possible causes for failed airway, and with the invention of all our modern airway adjuncts and our aids and much better emergency department training in the management of airway problems, it's become far less commonly used. So it was seen in one paper that with the tertiary training of emergency medicine specialists, you could reduce the frequency of proceeding to cricothyroidotomy from 1.8% to 0.2%. Things like the Lemon assessment, all those sort of things give you the chance to assess an airway prior to going in, which means you're less likely to end up in the failed airway scenario. So again, it's something that should be avoided, it's something that should not be taken lightly, but it's something that when you reach that situation, you should not hesitate to do. There are some situations where it is unavoidable. So severe facial fractures and injuries, that gentleman there, I probably couldn't avoid doing that, Crike. Advanced epiglottitis, again, you're not going to get an airway there. Congenital deformities of the upper airway, particularly Treacher-Collins syndrome, is the one which is quoted in most of the articles. Foreign bodies which are obstructing and cannot be removed, and anaphylaxis and edema which is resistant to traditional treatments. Contraindications, none. If the patient is going to die, they're going to die very rapidly from loss of their airway. So there should be no contraindication to this as a life-saving procedure. As an elective procedure, that's a different matter, and that can be discussed in another forum. The relative contraindications for this, severe bleeding diathesis can make the entire procedure far more difficult, and you should try and correct any bleeding disorder before embarking on it. But again, if it's an emergency, you just go ahead and deal with that later. A laryngeal fracture or a tracheal transection with retraction of the trachea and the thorax means there is no cricothyroid membrane to go through. Now, I did have a wonderful lateral x-ray of a gentleman who rode his motorcycle into a hockey goalpost or hockey crossbar and just transected his entire larynx, and everything ended up in the chest, and he wasn't very well. And there is no anatomy in his neck, which means you can't do this procedure. We ended up having to do a high thoracostomy and pull his trachea out and stick a tube in it that way. And in children, there is a lot of discussion on whether the cricothyroidotomy or the primary tracheostomy is the better option. It's well recognised in the younger children under 6, the tracheostomy is the preferred method. There is a bit of debate between the ages of 6 and 12 on which one is the preferred airway technique. So, as with all emergency procedures, you must be prepared. It's been stressed in one of the previous talks, and I will stress it repeatedly throughout this. Preparation of the patient will mean that you do not end up looking like a fool with egg on your face. So, prepare the patient. So you assess the patient for their indications, their relative contraindications, things that can muck up the anatomy, so obscured by obesity, by hematoma secondary to trauma, by previous radiation or tumours. If the patient is conscious and cooperative, it should be explained to them. It's a terrifying procedure. I'm just going to cut your throat, is one way to express it, and probably not the way I'd recommend. Position the patient and get the light optimal. A lot of these people, if they're having a great deal of difficulty and they have upper airways obstruction, will be in an upright position. They'll be sitting up. So get your light right. Do not lay them flat because you'll lose that airway sharpish. Prepare yourself. Prepare those around you. So you should only be doing this unsupervised if you're the most experienced person present. If there is anyone else more experienced than yourself, get them down. It's always better with friends. Prepare your equipment. Be familiar with what you have at your institution. Yesterday, we were using scalpels, a simple suture set, and a size 6 tube. Now, that's a great kit, and it's one which everywhere will have and everybody will have, even in the pre-hospital environment. But in many tertiary centres, there will be fancy crite kits, etc. Be familiar with them. You don't want to be using it for the first time in anger. So go to any teaching on it. If you've got a bit of downtime and you're the senior person present, pull the kit out, get everyone around and explore it with your friends. Be prepared with these things. And also brief all your staff as to what their particular role is, so that you don't have any confusion when everything has to be done swiftly yet calmly. All right, the anatomy of the region. We're all relatively familiar with this. This is the area we're aiming for. So the cricothyroid membrane, a vertical incision of 2 to 5 centimetres over the central ridge of the thyroid down to the cricoid, and then a horizontal incision across the membrane once you've dissected down to it. These are the things we don't want to be cutting. We don't want to be cutting these red fellows or the blue fellows. So if we choose a vertical incision, we'll probably miss them. The cricothyroid artery and vein will probably get damaged. They are relatively small compared to these big fellas. Two techniques are available to us, and as with most things in emergency medicine, they involve sticking sharp things into spaces of the body. And as with many things in emergency medicine, there is a needle version and there is a big tube version. So the advantage of the needle version is it's very quick, it's easier to perform, there's little training required, and there's less risk of vascular injury. The problem is it's only a temporizing measure. It will buy you 45 minutes of oxygenation, but it does not ventilate. In order to ventilate, you have to remove carbon dioxide. If you just needle insufflate someone, they will become hypercapnic and obtunded in somewhere between half an hour and 45 minutes. It's easily dislodged and kinked because it's a very small tube. And it requires positive pressure insufflation, which will mean somebody has to be on this at all times. Can't use a machine. The surgical cricothyroidotomy has the advantage it is a definitive airway if it is secured appropriately. It ventilates as well as it oxygenates, and it can be secured. The disadvantages are it's technically more challenging. It involves some training, it involves a confident operator. If the operator has a degree of fear, it may lead to a fatal delay. This is something, once the decision is made to do it, you should just get on and do it very rapidly. You've got very little time once the brain becomes hypoxic before you have irreversible damage occurring. So the needle, cricothyrotomy, will run through this very rapidly. We use a large bore needle, a 14 gauge or bigger. We approach from the head end at an angle of 30 to 45 degrees from the vertical. We identify the anatomy. If the patient is conscious, we put in local anesthesia, and then we pass the syringe, the needle and introducer and syringe through while aspirating until we get air. We then run the cannula off the needle and secure it in place. You can then use various different methods of insufflating oxygen. There is the Y cannula we can put in there. You can put in a bag valve mask off a 5 ml syringe, which attacks via a lure attachment. They're all possible. Again, that's something you should learn and practice before you get involved in doing it. The traditional time is 1 second on to 4 seconds off for delivery of oxygen. Now I'll move on to the surgical cricothyrotomy because this one's far more interesting and has much better pictures. So identify your anatomy. As we went through yesterday, the anatomy is generally quite easy on slender gentlemen, but when you're looking at ladies, there is less prominence of the Adam's apple, and when you're looking at obese people, very bearded people like the previous gentleman, it becomes very challenging. So take some time to identify that anatomy. Then do a vertical incision to avoid those significant vessels. Identify the cricothyroid membrane. It is a white membranous layer. Use a horizontal incision with a stabbing motion, and then replace your sharp object with a blunt object to keep it open while you dilate it. Introduce your tube. In these diagrams, they're using a very fancy kit. A 6 tube will be appropriate. Size 6 ET tube is the smallest tube, which routinely comes with a cuff. So that's the tube we'll generally use. Secure it in place, and then assign somebody the role of looking after that tube, because if you lose that tube, it becomes very problematic. You can then bag them, or they can be ventilated through a ventilator at that stage. Okay. Are we on time? Good. We're moving on to the breathing part of the talk. The thoracostomy is a procedure, as again I said with the emergency medicine procedures, it involves putting a tube into a space. And the key is to get the right tube in the right space, and that's all it's down to. So in this particular situation, we're putting it into the pleural cavity to drain primarily air or possibly fluid from the pleural space. Its role is widespread. There are many indications for this, but we will only consider the relief of the tension pneumothorax because that is our life-threatening, or massive hemothorax, because they're our life-threatening conditions. The other indications are best dealt with in another forum. All right, tension pneumothorax. It's a life-threatening emergency. The clinical signs, people with worsening dyspnea, hypotension, diminished breath sounds on the affected side because the lung is no longer there. Distended neck veins because the venous return to the heart is obstructed by kinking of the great vessels. And tracheal deviation is a very late sign, and it's away from the affected side. I was always taught you should never ever see a chest x-ray of a tension pneumothorax. And in this particular situation, I thoroughly agree because this patient is clearly in some degree of distress. As you can see, the right side of their chest has nothing in it apart from air. The trachea is significantly deviated. The heart has been moved significantly. This person is going to be shocked. So, as we said previously, prepare your patient. Prepare yourself, prepare your equipment, and prepare all those staff around you. So confirm you're going into the appropriate side of the chest. If the patient is conscious, explain that you're going to be popping a big needle into their chest or possibly a large tube. Position the patient and get your light and equipment optimal. And then administer local anesthesia or sedation if the patient is fully conscious. Make sure, once again, that you're the most senior person available or the most senior person available is next to you. Be familiar with the equipment you use, particularly the kind of valves, underwater seals, etc., 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 that are available because they differ in different places. Otherwise, the basic needles and tubes are pretty much the same. And again, assign roles. So, as before, there is a needle approach and there is a tube approach. The needle, as before, is quick, easy to perform with little training. It is only a temporizing measure. So we're seeing a pattern here. Little tubes, they're good for the little things, but if you've got a big problem, you need to put a big tube in. They're only useful, obviously, for gases. They can easily be dislodged or kinked. So again, once you pop it in, get someone to watch that and make sure it's patent at all times. And requires replacement with a definitive tube at your earliest convenience. It is, again, as I can't stress this enough, a temporizing measure. The advantages of the big tubes: they drain both liquids and gases, and it depends on the caliber of the tube, what you drain with what tube, and we'll discuss that in a moment. It allows large volumes to be drained rapidly, though I have had situations where you have to put multiple tubes in. So if you have someone who's ruptured a lung off completely, I had a gentleman who managed to rupture his lung off at the right main bronchus by falling out of a tree, and he required 5 tubes before he finally stopped tensioning. And in fact, a thoracostomy. But there we are. They can be securely attached. They don't need that much watching and management once they're in. And they can also be attached to suction and other such things. And if you do need to do pleurodesis and stuff, it can be introduced through the tube. So they have certain huge advantages. They're technically more challenging. There is a risk of vascular injury. And again, people who are not used to doing them may become reluctant to do it and cause a fatal delay. So we'll go to the needle thoracostomy, as I said first. So second or third, intercostal space, midclavicular line. We all know this. Aspirate as the needle is advanced, or if you really want to get the drama up, and if they reckon there's a good bit of tension in there, just pop the needle through and listen for the hiss. Once the air is encountered, remove syringe and fix the cannula to the skin. As this will demonstrate, I think we can see, as this lung expands and that needle is through the chest wall, there is a good possibility that will get kinked off. So have somebody watch this carefully, because you will need to put in definitive drain at some point. The tube thoracostomy, this is a technique, and it's the most difficult thing I've ever had to try and teach someone, because it's very much about how it feels. You can teach someone how to do it, etc., but until you've experienced it, it's a bit like those cricothyroidotomies that people we were doing yesterday. Until you've actually got your finger in there and had a little feel, you don't know what it feels like. So explaining how to do it, I think, is probably difficult in this scenario. So I thought we'll just have a few pointers. Air can be drained through small tubes. size 8 to size 14 French. You can get size 8 Seldinger technique ones, which are very popular for the drainage of spontaneous simple pneumothoraces, and a 14 is good for attention. A traumatic hemothorax will require a big tube, so 32 French or above. And remember, for a tube that big, you need a big hole. The position of the tube should be in the anterior axillary line, 5th or 6th intercostal space. And in most people who aren't Greek, that corresponds with the axillary hairline. And if you have to put a second one in, go where you put your needle. 2nd intercostal space, mid-clavicular line if you need a second tube. And for low-lying fluid collections, etc., they should be done under ultrasound guidance, because once the anatomy becomes embarrassed by the initial insult, you can end up going into subdiaphragmatic structures such as the spleen and the liver, which looks poor.
Hang on. We did this in the airway workshop yesterday about how you locate the cricothyroid membrane. I think, are you happy if I mention that? Yep. So you should do it on yourselves. Thank you, sir. That was excellent. Wait up here, just in case. Wait up here, in case I get it wrong. Wait up here. So cricothyroid membrane, how you locate it. In the male, the first thing you're going to do, one I prepared earlier. The male, the first thing you're going to feel is this thyroid notch, the Adam's apple. And then you'll go down and there'll be a little divot. And that's your cricothyroid membrane, and then you've got your cricoid ring. That's how you find it in the male. Start from the top and go to the bottom. In a female, you start from the sternal notch and go up, and you feel the cricoid ring, and then you feel the cricothyroid membrane. Okay, as you saw the little artery and vein, it's going to bleed, but go through it. The other technique, apart from the one that you mentioned, is if you don't want to make a cut through it, I've seen this with a finger. You can stick your finger through the cricoid. It's not, you know, like a piece of tissue, but you will have to put some force in. The other thing you can do instead of using the hooks is you might be able to put a bougie in to keep it open and roll a 6 tube through. Would you be happy doing that on the field if you had it, or would it be too difficult?
I've always liked to put a decent sized hole and get my finger in it, because the trouble with it is often you can produce a false lumen and strip off the lining of the trachea, and then you end up getting the bougie in, which will propagate the false lumen. Then you put a tube in, and the tube stops mysteriously after about 4 or 5 centimetres, and then you've created a false lumen. Finding the true lumen is harder. You've just made your whole life worse. So if you get your finger in, you know you're not.
Okay. Thanks, Will. Thank you very much. Well done. Okay.